So with this, let me hand over to Dr. Nakatani for chairing the conference.
Thank you. Thank you, Gundo. My name is Hiroki Nakatani, Assistant Director General in charge of HIV, tuberculosis, malaria, and neglected tropical disease. My role today is to introduce the subject and then also introduce our colleague panel members. But my biggest challenge is in timekeeping. So, colleagues, I think our press colleagues would like to make and ask many questions. So, let's make our presentation very short and crisp, and then open floor. But before doing so, I would like to just stress so the context of this event, that is press conference of new strategies, new guidelines, and new focus, WHO, HIV, and key population. It is because, as Gundo just mentioned, that there is a series of WHO documentations which were launched yesterday. The first one is global updates of where we are. So it is very encouraging that our treatment has been expanding very rapidly and in very good way. So we will be able to achieve 15 million treatments by 2015. So that is very good sign, but the progress is very patchy. So one area which we must see a lot of progress is our access of treatment care and prevention among key populations. That's why we are focusing particularly key populations challenges. This is why what we have consolidated various parts of relevant guidelines and others into one that will be user-friendly. So this is background of a consolidated guideline for key populations. So we have today supposedly 7 prominent speakers, but one speaker, Kate Cordova, was prevented to come due to unavoidable reasons. So maybe I think we stay with the 6 presenters or panelists. So I think I will call each one of us 6 speakers, and I will just introduce who he or she is, and then give, I think, as crisp as possible, I suggest you to speak 2 points, if possible, and then if more than 5 points, I think I will pat shoulders. So this is my work. Now, the first speaker is, I would like to invite Dr. Gottfried Hinschel. He is a director of HIV department of WHO. Gottfried, floor is yours.
Thank you very much. And good morning, everybody. Great to have you. As Gundo has said, we are launching 2 important documents. One is I would call a landmark report. It's a global update on the status of the health sector response. The other one, very much with the theme and I think the conversations that are ongoing in this conference, it's the WHO guidelines on key populations. So 2 real key documents very much in line with the conversations and the discussions this week. The global update basically speaks to the status of the health sector response, and I would like to pass 3 messages there. First of all, over the last few years, we have seen major progress in many areas. Specifically in the area of treatment, 13 million people have been on treatment by the end of 2013, which constitutes the biggest increase in 1 year ever. 2 million people have been added in 2013. We are also seeing progress in other areas. More women are able to access medication to prevent the transmission to their babies, prevention of mother-to-child transmission. Nearly 1 million people were able to receive treatment so that their babies would not be infected, which is a major progress. We are also seeing that some other preventive interventions have been scaled up. Medical male circumcision. Many more men have been circumcised in sub-Saharan Africa, where this intervention is most relevant over the last year. Major increase. Second message. There is unevenness in the progress that's been made. It's not the same in all parts of the world. We see certain parts of the world that make very good progress. Among those is Sub-Saharan Africa, and there specifically Eastern and Southern Africa. But we also see other parts of the world that continue to fall behind. That's North Africa and the Middle East. This is parts of Eastern Europe. This is also certain parts of Asia that are falling behind. Third message is key populations, and we define key populations as men who have sex with men, sex workers, persons who inject drugs, transgender persons, and persons who live in prisons or other closed settings. In basically all parts of the world have compromised access to good services. In many parts, they have an increasing rate of new infections. We see this specifically in men who have sex with men, very concerning. I would call them explosive epidemics in many parts of the world, with rates that we haven't seen before, maybe very early in the course of the epidemic, but certainly not in the last few years, but also in other parts, in other populations. For example, transgender persons have a risk that is up to 50 times higher than the general population to be HIV positive. MSM 13 times higher, sex workers about 15 times higher, etc. So these populations obviously deserve specific attention. They are also basically throughout the world, they continue to be stigmatized, in many instances discriminated, and live in places, in countries where laws continue to penalize their behavior and obviously deter them from seeking services, even in case they exist. In response to this, WHO has sees the work on key populations as one of its priorities, and we have over the last year given great emphasis in a very consultative process with our partners to develop key population guidelines. The idea of these key population guidelines really is to inform those who make policies in countries what is the right thing to do, what is the right thing to consider, what are the interventions that they should implement, but also to think about what we call the enabling environments, the legal frameworks, discrimination that occurs even in the health sector, and also, very importantly, to think about issues of violence, to think about issues of community participation, so that really the environment is such that these interventions can be delivered. So that's why we as WHO see this as a top priority for us. We also strongly believe, and we are convinced, that unless the global community and countries obviously have to take the lead in this context, put a lot of emphasis on redressing this imbalance and really focus on key populations, our vision of ending the AIDS epidemic by 2030 will not become a reality. Hence our focus.
Thank you very much. We will continue, and second speaker is Dr. Rachel Begley. She is coordinator of our key populations and prevention HIV departments. She has coordinated the work of this guideline, and she is worked with Chris, who is serving as our technical advisory group of this, and also she worked with member states as well of affected communities, which many of fellow members represent here. So now, Rachel, floor is yours.
Thank you very much, Dr. Nakatani. I'm very pleased to be able to share with you these guidelines today. As my director, Dr. Hensel, has said, this has been a very collaborative, very collaborative process. We had on our guidelines group people from the networks of key populations, people representing organizations working with key populations, as well as people from ministries of health, implementers. And these guidelines are really meant to give countries what they need to provide accessible and effective services for key populations. And we we run through what we call the continuum of care, describing all the prevention interventions, ways to increase access to testing, and the whole comprehensive care, HIV care, and all the other care interventions that are needed for key populations. Just to add on to what Gottfried said, critical for health services to offer services for key populations are the enabling environment, and we stress here very strongly the interventions that are required to address these so that more people from key populations can access services. We also have a number of case studies. We asked our partners and other communities to give us case studies to show how that they can provide services for key populations, even in legally constrained settings. We hope very much that we can now really get this out into countries, into ministries of health. We recognise that we're going to have to do this with community-based organisations. The response for key populations is very much in partnership. As Gottfried said, we're really facing a changing epidemic. UNAIDS now estimates that up to half of all new infections are in key populations, be that in the traditionally generalised epidemics or in the countries where key populations have always been the focus. So this is really the start. We're very pleased that we have been able to develop this with our community partners and with Ministry of Health partners, and we now have a tough road ahead to try and make sure this doesn't remain as a document, but actually gets out and the key populations receive the services that they need and deserve.
Is that all?
That's all.
Oh, thank you very much. So,
You wanted it short?
yes, thank you. But I think, as I said, Rachel coordinated inputs and advice from scientific communities and affected communities and also member states. So I think I will be a little bit generous about time. So may I invite Dr. Chris Bela. He is, as stated here, Director, Center of Public Health and Human Rights, Johns Hopkins University, and also IAS President-elect, Congratulations. And also, important function why he is here is he served as the chair of Guideline Development Group. Now, floor is yours, please.
Thank you very much, Dr. Nakatani. Good morning, everyone. I'd just like to begin on behalf of the International AIDS Society to thank WHO. We really appreciate your engagement, your participation, and in fact, using the platform the IAS has built this conference to launch these guidelines. We think this really is a very important contribution to the global conversation on AIDS, to the effort that we're all engaged in together, and we really appreciate that collaboration and ongoing support. I just want to make a few comments. These, of course, are consolidated guidelines on treatment, on testing, on prevention, on the full comprehensive services. But if I might, I will focus my comments specifically on the prevention elements. And the first thing that I want to say is that I think that these guidelines represent an important advance both in public health and in human rights. With this tremendous focus on key populations, with the community consultative process, and with the ongoing nature of the guidelines. This is a living document, and as I'll speak to in a moment, it is going to continue to evolve, and that, I think, is a critically important thing to keep in mind. One of the major prevention advances in the guidelines is the recommendation for pre-exposure prophylaxis, what's commonly known as PrEP, to be considered as a prevention option for men who have sex with men, gay and bisexual men. I think this is critically important, and we were very, very careful in reviewing the evidence. There is strong evidence for this recommendation. We came to a consensus on the science behind this, but that it be considered an option for men who might want it in the context of a comprehensive set of services, package of services for men who have sex with men, which would include, of course, condom distribution and promotion, appropriate water-based lubricants, education, community outreach, and working on the environment, the legal policy, stigma and discrimination context that we all know are such important barriers to access to services for gay and bisexual, other MSM. I want to make a point, and I'm delighted that there members of the media are here, because we have had some concerns, and we have heard from the community, certainly some concerns about the initial media response to this information, which has somehow implied, quite mistakenly, that WHO somehow had recommended pre-exposure prophylaxis or antivirals for all men who have sex with men or for all gay men. What these guidelines say very explicitly is that this is an additional prevention option that should be considered based on the scientific evidence for men who want it. And I think if you think about this, a very analogous situation, and one that I think has helped all of us kind of think through these challenges, is to think about, for example, contraception and family planning, where we offer, and medical science, public health offers multiple choices. We don't say all women who want to avoid pregnancy should be on the pill. We don't say all women who want to avoid pregnancy should use condoms and only condoms. We have a variety of options. Women, couples have a number of choices, and those choices can change over the course of the life cycle. People may, of course, choose contraceptive pills in reproductive years, and then may choose IUD or tubal ligation later on in life. There are a range of options. PrEP is not being considered or recommended as a lifetime approach. It is really critically important for men to consider as an option for prevention when they are sexually active and at risk of HIV exposure. That's critically important. I'd like to add, I think another really important aspect of this is there is not, as you will see in the guidelines, PrEP recommendations for the other key populations in terms of initiating PrEP guidelines now, but rather an agreement which really came out of the community consultation for ongoing evaluation of demonstration projects, a call for more demonstration projects specific to populations like transgender women who are at such risk, as Gottfried was saying, of HIV acquisition, for sex workers of all genders in whom operational issues and use of PrEP really needs to be explored with community and with partners, and that process is ongoing with a number of the networks. And the outcomes of community consultations and discussions at the community level are feeding back into the WHO and into this guidelines process, and will continue to inform as the guidelines go forward. I think that is really very important. Let me just make two final points. One is that the guidelines have also recommended the community use of naloxone for prevention of overdose deaths. I think that is something that the community of people who use drugs and the providers who care for them and their families and friends are enormously excited about. That is a real advance again, in life-saving intervention, a public health approach, but also a human rights advance. Finally, I think it's absolutely essential to point out that these guidelines, for the first time, acknowledge the challenge and the importance of paying attention to youth, to adolescents who come from key populations. This is a group that has been traditionally extremely challenging to serve for a variety of reasons, and I really want to recommend the WHO for its leadership in taking on this issue and including our kids at risk. We all know how important this is, what a challenging time adolescence is, and particularly for adolescents from sexual and gender minorities. So I really want to thank the WHO for that.
Thank you, Chris, for very kind words. The next speaker is Mr. Atapon Ed Nungukis. I'm sorry that I can pronounce
It's okay,
you well.
my family name is quite complicated.
So, Ngoksim.
Okay.
And then he is key population officer at the global network of people living with HIV based in South Africa. Floor is yours.
Thank you. I would like to take this opportunity to highlight that there are three things that make this guideline significant. And most importantly, I think the guidelines really emphasize what the communities have been saying, that, and the media also portray us in a different way. The guidelines help us to make sure that we need to really change the false paradigm that key population drive the epidemic. This guideline, what it says to you, really lack of services and access services that drive HIV epidemic and continue to represent a major barrier to achieving our health, our human rights, and also dignity. Especially when it's only 8% of key population, including people living with HIV, have access to prevention care, treatment services that they need. These guidelines are really critical to the much-needed scale-up of access, and our community can use these guidelines to demand for better health services. Secondly, as Chris has rightly said, it's really put the human rights as a core principle and articulate the importance of meeting the right to health of key populations. So it goes beyond just the health sector, but looking at making a very strong case to government and donors as to why addressing critical enablers, such as removing legal barriers, reducing stigma and discrimination, and supporting community empowerment, addressing violence, will allow our community to access the service better. And the third point is what really is significant about it is how it was developed. It was really developed in full partnership with key population and community of people living with HIV, such as my organizations, who have played a critical role in involving as a global guidelines development groups, and also inform our studies inform the value and preferences studies of these guidelines, and also we help to draw a lesson learned from our programs and interventions that we implement in our communities. So what I want to say is that this is another tool at our disposal to demand the right to health for populations underserved who face a lot of stigma, discrimination, and other laws and attitudes and problems, to generate demand for services, and using this tool to hold government accountable for adopting and also implementing the guideline. And our communities, such as GNP+, we continue to work with our partners to make sure that our communities understand what the guidelines say. And for example, our work around the community guide that we launch tomorrow really talk about how to translate that into the language the community can understand, take ownership, and work with the government to make sure these guidelines are implemented. Thank you.
Thank you very much. This guideline has a lot of clinical implications. So now it's my pleasure to invite Dr. Philip Reid, who is a sexual health physician in Sydney. You are looking after key populations in your district. So floor is yours, Philip.
Thanks very much, Dr. Nakatani. Yeah, so my name is Philip Reid. I'm the medical manager of an integrated primary care clinic in Sydney called the Curtin Road Centre, which has a focus on the prevention and treatment of HIV and other transmissible infections amongst people who inject, sex workers and other at-risk young people in our area. And I was asked to talk a little bit about some of the new guideline recommendations relating to people who inject drugs. And I think there are three things which are really interesting, and I'll highlight those. The first one, which is the newest recommendation, as Dr. Bayer mentioned, is the addition of the distribution of naloxone to people who inject. We know worldwide that over 69,000 people a year die from heroin or other opioid overdose. And for people who inject, who are also living with HIV, if they're on treatment, they've actually got a greater risk of overdose causing their death probably than HIV itself. In Australia, that relates to 1 to 2 people every single day who die of heroin or other opioid overdose. Now, we also know that 60% of those overdoses they occur in the presence of somebody else. And that's a real opportunity to intervene. Heroin overdose works by suppressing your respiratory rate, your breathing, and the time to somebody responding is really critical in saving lives. So if there's somebody at the scene, either the person themselves can administer the naloxone to themselves, or a peer can administer the naloxone to them and reverse that overdose, it's not only going to be life-saving, but it's also going to reduce the morbidity associated with overdose, because not all overdoses result in death, but we do know that people who overdose repeatedly have a higher incidence of acquired cognitive impairment. So there's lots and lots of reasons, I think, to be excited about the inclusion of this in the guidelines. Now, it has been instituted in some countries worldwide, and Australia is one of those. At the Kirkton Road Centre, we've been responsible for rolling out the distribution of naloxone to people who inject and their peers, and similar organisations in other states and territories of Australia, such as in Victoria and the Australian Capital Territory, have also been proactive. During the pilot phase of our experience, one thing that came through very strongly was that people who injected drugs really wanted to be empowered to be able to respond in that situation. Almost all of the people who were opioid dependent had witnessed an overdose, and almost 2/3 of them had overdosed themselves, and they really felt this was an important intervention to include. It was also very apparent that it was easy to incorporate naloxone in overdose management packages for that population. And in actual fact, in the first year of us rolling out this program, 20% of the people who injected drugs we supplied naloxone to, in fact, actually used it to reverse an overdose. The other two aspects of the recommendations for people who inject drugs that are worth mentioning at this point is the recommendation for continued and expanded access to needle and syringe programs. I think the importance of needle and syringe programs in bloodborne virus prevention for people who inject can't be overstated. In Australia, we've been fortunate to have had a comprehensive needle and syringe program across the country since the late 1980s. And the prevalence of HIV in heterosexual people who inject drugs is less than 1% across the country. In fact, in 2012, just 21 people in the entirety of Australia acquired HIV where injection of drugs was the primary route of transmission. It's also been estimated to have averted over 50,000 cases of HIV in Australia, not to mention over 100,000 cases of hepatitis C. And to put that into context, there are less than 30,000 people in Australia living with HIV. You can see the impact has been huge. But not only ethically, but also medically it makes sense, but also economically. And we know from extensive evaluations that for every dollar spent on needle and syringe programs, over $4 is returned to the state in direct cost savings. So it's effective on a number of levels. However, across the globe, less than half of countries have comprehensive needle and syringe programs. So I think we mustn't lose sight of the importance of promoting that as well. And I'll just finally also mention the importance of opioid substitution therapy or opioid agonist therapy. This has a number of benefits for people who inject or people who are opioid dependent. Obviously has medical and social advantages to injecting. The risk of bloodborne viruses is less. The risk of injection-related disease is less. And crucially as well, the risk of overdose, which we touched on already, is less. So I'll conclude by saying how pleased I am as a clinician in the field in a high-income country to see these recommendations put so strongly and clearly, and it really helps me to be able to continue to advocate for integrated services for people who inject in services that are orientated around HIV treatment and prevention as well. So thanks to the WHO.
Thank you, Philip. This guideline need to be adopted at national policies. And our next speaker and last speaker is Dr. Fabio Mesquita. He is leading one of the most successful HIV programs in big country Brazil. So floor is yours, Fabio.
Thanks, Dr. Nakatani. I think for us as countries, as implementers of WHO guidelines, I can say that these guidelines on prevention for key affected population is a landmark in the history of HIV. We can say that about countries that have concentrated epidemics like Brazil or US or the countries in Europe or Southeast Asia, but we can also say that about the countries in sub-Saharan Africa where they got a strong success in controlling the epidemic among generalized epidemic and general population, but not in key affected populations. So this data that was presented right now in the plenary of the first plenary of this conference by Dr. Salim Abdul Karim shows also that we need to change the way we work. We need to change the business. Otherwise, we will not control the epidemic. So, or we focus on key affected populations, or we have no future in controlling the epidemic. And that was a very clear message for the session in this morning. The reason why key affected population is more affected through the epidemic was just pointed out by Eddie, when he says that they are left out in terms of human rights, they are left out in terms of provision of services, and they have more difficulty to access to prevention, services, care, and everything that we know it works. And we learned in the last 3 years that besides everything that we have been doing, there are new tools and new technologies that can be used and can affect the epidemic. Also in the plenary this morning, we saw the progress of the epidemic in perspective if we do the business as always and if we use the new technologies. And it's completely different. So one of the goals, besides everything that was said already here, one of the important instruments that these guidelines point out is the use of treatment as prevention. And we can talk about, of course, we need to keep doing the classical prevention, promotion of condoms, harm reduction strategies and everything. We need to keep enable environmental. So Brazil, about 1 month ago, approved a law that criminalizes people who discriminate HIV, people living with HIV. We need to keep doing that. But also we need to add new technologies. So treatment as prevention is being adopted in some countries, like in Brazil. From December of last year, we are implementing treatment for all HIV positive. We do post-exposure prophylaxis, right? From 2012 is in the Brazilian guideline and is now in the WHO guideline, saying that post-exposure prophylaxis should be for every kind of accident, not only for health professionals, but for we can prevent the spread of HIV using PEP. And the novelty of this guideline that we presented yesterday is PrEP as something additional that we know it works, we know it's important, but we don't have the experience of implementing this in services. So what we are doing today in Brazil is 2 big studies that is supported by the national government, together with Fiocruz in Rio de Janeiro and together with the University of São Paulo in São Paulo. We are engaging this study 1,300 people. One study, the Fiocruz study, is only about PrEP in men who have sex with men, and the other study is every key affected population. And what we want to learn is how PrEP, that we have the evidence that works in science, works in real life. That's a big question for all of us in the world. So how in public health services, how in the day-by-day services, we can think about PrEP as an alternative. So this is, again, a very important tool, these new guidelines, for all countries in the world to update the way we do prevention, the way we do business, and to really think that now we have a light in the tunnel, and we can consider that is not a crazy idea to end the level of the epidemic of AIDS by 2030. Thank you.
Thank you very much. Now, you have heard all a presentation of panelists, and I would like to open floor to questions. So when you raise questions, please identify yourself and to whom you are going to pose questions. Floor is yours.
Thank you.
Please.
Jan Huiblands, Dutch National Radio. I have a question about the mix of prevention strategies. My impression is that people change from one strategy to another instead of adding strategies to fill it up to 100% or at least as high as you can go. That might be called human failure, but do we have any information about this phenomenon? And if I may, sir, a second question.
Yes, go ahead.
For Rachel, could you mention 3 failures, so to say, in the health system that are more or less general occurring? Thank you.
Okay, do you have any more questions? Okay, it's the first question. Oh, excuse me.
Hello, yeah.
Please go ahead.
Is this on? Yes. I'm Gus Cairns from AIDS Map in the UK. I'm also community co-chair of a PrEP trial, so I know a lot about PrEP. My question about the PrEP recommendation is not really why PrEP, but why exactly now? Tomorrow we're going to hear the first ever results of a large open label study of PrEP. The first sort of real life, as you might say, application of it. Have you jumped the gun? Is this too soon for a recommendation to include PrEP?
Thank you. So I think so far, shall we ask to respond? First question, a mixture of prevention strategy. Chris, would you like to answer? And then health system issue. Gottfried or Rachel? And why now question. Rachel, do you think? And PrEP is very much concerned of Fabio. Would you like to add voice in this order? Is it right? Good. So Chris, go ahead.
Surely. Well, I think the question about the comprehensive nature or the combined nature of prevention is really a critical one. I think if you look carefully at the data, particularly at the outcomes of trials like IPREX, where we learned about the efficacy of PrEP for men who have sex with men and transgender women, these are by their nature combination intervention trials. Because the control condition, so everybody is getting the basics of things like regular HIV testing and counseling, everybody is getting treatment for their sexually transmitted infections, everybody is getting education, condom promotion, and water-based lube. I think one of the things that is critically important to understand, both about pre-exposure prophylaxis, PrEP, and also about treatment as prevention, the use of treatment as a prevention tool, is first of all that both of these are HIV status-dependent interventions, which means that the cornerstone of them is HIV testing and counseling. And of course, for folks who are at risk, for men who have sex with men, regular testing ought to be a part of the intervention package altogether, but it also is additive with PrEP. The second thing is that we have learned from, and to our challenge in many cases, that all of these newer generation interventions are very dependent on adherence. They depend, the Achilles heel of these approaches is adherence and use of the tools. So that means that support for adherence, the counseling components, the education components, the proper use and support of people who are on these agents is going to be a critical part of their success. And again, it underscores that they are all, by their nature, combined interventions that require behavioral testing, counseling, adherence support, and also the use of the new tools.
I'll start with the question about the 3 things that the health systems are doing wrong. I think one of the key these WHO's main constituent is the health sector, and we really want the health sector to take these recommendations on board. And one of the reasons that people from key populations don't come to the health sector is because of the attitude of healthcare workers. And healthcare workers often inadvertently do not provide services that are acceptable. So this is to encourage training of healthcare workers to understand the needs of key populations and provide respectful services that meet their needs and are delivered in a way that is successful. Another failure, if you like, is the parallel systems that we have, community systems run by NGOs, which are often really fabulous, and then the health sector. And for comprehensive care and support for key populations and prevention, you need much more joined-up services and the acknowledgement and the legitimization of the community-based services by the health sector. And so, to really, with our case examples and further work that we're doing. Okay, I've got to be sorry. He's telling me to be very crisp and quick. So, and the third failure at the moment is a very vertical approach that we have to delivering care, and I think a much more integrated approach. So, integrating HIV services into harm reduction services. So those are my failures. Just to now talk a little bit about some of the questions relating to the PrEP, the risk compensation. What we do know from trials is that people who have been in trials for PrEP, possibly because of their frequent contact with healthcare workers, actually we haven't seen reduction of condom and lube use. We've actually seen increase. And with regular testing as well, there's an opportunity for more health contacts, more health advice in a general as well as an HIV way. Furthermore, from the IPREX-OLE study, the people who then wanted to continue with PrEP were often the men who had lower condom use. It wasn't that PrEP was causing low condom use, it was the men who, for whatever reason at that time, had found it more difficult to use condoms, were choosing PrEP as something to help them with HIV prevention. And to answer, are we too early? I think it's a big tension, and I've certainly talked to your colleagues from the PROUD study about this. In fact, they were well aware that we were doing this, we were discussing this earlier in the year. And I think very much from our guideline group, why we made the conditional recommendation in 2011, so here we are 3 years later, we're now making this what we call a stronger recommendation. We still recognize we don't know the best way to do it. And we also recognize that we need to monitor and evaluate and document this. And as Chris, our guidelines chair, says, this is a rolling process, and we are committing to update this, and we will be very, very responsive to the results of the trials as they come on board.
Fabio.
Yeah, why PrEP now? Besides what Rachel just said, that I totally agree, I would say I will go back to the presentation of Professor Salim in the plenary, where he showed that epidemics that are mature and are long-term epidemics, like we're not talking about new epidemics, but talking about Thailand, or talking about US, or talking about Brazil, we see, and he presented that, the level of use of condom is going down, despite all the efforts for the promotion of condoms, and despite all the efforts that the governments are pushing. The real life shows that people some people just gave up or stopped to use condoms. So we need to have options, and this is a proven by evidence-based option, and we need to try. And what we are doing is try to study first if there is acceptability of the community and if there is potential to distribute that in a real life in the public health service. If there is, as part of a package of many other interventions, why not now?
Thank you. I think next time our press conference is queued. So last word, very last word from Gottfried, and let's close. No?
Well, I was actually going to say what Fabio said, basically throwing back the question to say an intervention that we know that works, where we still have to figure out how best to apply it in an epidemiologic situation in which we find ourselves with really increasing rates of new infections. I think we really need to bring this to application and to implementation as quickly as possible.
Thank you. If you have more questions, Gundo is going to coordinate, and WHO office is located 208. Thank you very much.
Thank you, everybody. So just